The last areas we will focus on in interventions and prevention measures for individuals with cardiovascular disease are secondary prevention or management of risk factors, special patient populations, and medical and legal concerns. Early intervention is probably the most important factor in preventing further CVD, and education plays a significant role. This education can begin immediately after the crisis stage is over, sometimes as early as 1 to 2 days after the event. In the outpatient setting, the patient's educational level should not be the limiting factor in understanding their disease and risk modification. This information can be provided in both an individual or group setting. The core components of a secondary prevention program have been outlined by the AHA and AACVPR and include baseline patient assessment, nutritional counseling, risk factor management, which includes lipids, blood pressure, weight, diabetes mellitus, and smoking, psychological interventions, and physical activity counseling. Diet and nutrition should fit the patient's lipid profile, cultural background, and lifestyle. Parameters such as height, weight history, and percentage of body fat should be obtained. Lipid profiles, electrolytes, CBCs, BUN, creatinine, prealbumin, and serum albumin should be obtained. Since obesity is a significant risk factor and has a direct effect on serum lipid levels, weight loss should be an important part of any cardiac rehab program. Food diaries and nutritional history are key to this plan. Psychological recovery after a cardiac event can be influenced by the degree of anxiety, depression, or denial. The risk factors for adjusting after a critical event will be discussed shortly. Risk factors for CVD when looking at lipid levels are total cholesterol greater than 220 milligrams per deciliter for patients 20 to 39 years old and greater than 240 milligrams per deciliter for those older than 40, low-density lipoprotein, LDL, greater than 100 milligrams per deciliter, and an extremely high risk for LDL greater than 175 milligrams per deciliter, high-density lipoprotein HDL less than 35 milligrams per deciliter, LDL to HDL 3 to 1, and triglycerides greater than 200 milligrams per deciliter. Patients who are at an increased risk may also be placed on a moderate or high-intensity statin. The risk factors for adjusting after a critical event, as mentioned before, include patients living alone, patients who are not married and do not have a confidant, patients who are recently divorced or widowed or socially isolated, from multi-problem families, patients with low incomes, who smoke or are obese, have multiple chronic illnesses, who are without spiritual or religious comfort, have a history of mental health issues, or patients who are less self-reliant and optimistic. Patients are identified for psychological risk factors using either clinical interviews or psychosocial screening instruments at program entry, exit, and periodic follow-ups. The measured outcomes for this component are improved emotional well-being as evidenced by lower levels of depression, social isolation, anxiety, anger, hostility, drug dependency, or excessive psychophysiological arousal. The behavioral goals allow the patient to describe the recovery and rehabilitation process, assume responsibility for behavioral change, obtain effective support, demonstrate stress management skills, and reduce use of tobacco, caffeine, and other non-prescription drugs, and ultimately return to meaningful social, vocational, and avocational roles. A major problem in all cardiac rehab programs is compliance with lifestyle modifications. Only 20 to 50% of participants continue to exercise after 1 year. Factors that may contribute to this lack of compliance include duration of rehabilitation, regimen complexity, the nature of side effects and presence of symptoms during the regimen, social and environmental factors, and the patient-therapist interaction. Strategies to improve compliance include recommending facilities close to the patient's home or work, scheduling programs at convenient times for both working patients and retirees, ensuring parking and locker rooms are convenient for the patient, establishing rapport with the patient and their family, encouraging family participation in the program, giving patients immediate feedback on their progress, and asking for patient feedback as to satisfaction with the program. Outcomes for all cardiac rehab programs fall into 4 domains. They include behavioral, clinical, health, and service. Some examples of behavioral outcomes include smoking cessation and diet and exercise. Examples of clinical outcomes include weight, blood pressure, lipid profile, oxygen saturation, symptom management, and the number of physician ER visits. Health outcomes may include quality of life measures, vocational status or independent living status, and service outcomes are related to patient satisfaction, financial, and economic issues. The benefits of cardiac rehabilitation are well documented by the Agency of Healthcare Policy and Research, AHCPR, and include improvement in exercise tolerance and symptoms, improvement in blood lipid levels, reduced cigarette smoking, improved well-being, and reduced stress and mortality rates. Factors that are not affected by cardiac rehab exercise training alone are body weight, rates of non-fatal reinfarction, ventricular ejection fraction abnormalities, and occurrence of cardiac arrhythmias. Routine follow-up should be done by each team member with the patient at least twice a month during the subacute and intensive rehabilitation phases. Patients should be considered for discharge from a program when the anticipated goals and desired outcomes have been met, the patient declines further intervention, and when the patient is unable to progress toward goals because of medical or psychosocial complications, or the patient fails to make reasonable progress towards goals due to non-adherence or failure to attend scheduled appointments or unwillingness to participate. Special patient populations may need additional monitoring and support. A special interest for the respiratory therapists are patients with COPD in addition to CVD. They should be continuously monitored for desaturation during exercise and instructed in pursed lip breathing exercises. O2 may need to be titrated and dyspnea scales utilized. Other special populations include patients with multisystem issues, women, children, and the elderly, patients with peripheral arterial diseases, patients with diabetes mellitus, and patients who have had a stroke or have renal disease. Proper documentation and record keeping is essential for evaluating the value and validity of a rehab program and assuring quality. The contents of proper record keeping include an attending physician referral and authorization, pertinent medical data, initial evaluation, regular progress notes, monthly reports and log records, and a discharge summary. Lastly, medical and legal considerations should also be noted. Legal concerns generally fall into two aspects of the program. They are adverse effects of medically prescribed exercise testing and fitness conditioning, and consideration of disability pension and insurance benefits that may influence the patient's motivation to return to work and may affect the attitude of an employer toward a person with a quote-unquote heart problem. It is important to always properly supervise and monitor the patient and know when to terminate a session when potentially dangerous situations arise, and there must also be adequate advanced preparation and training for emergencies in accordance with generally accepted medical standards.